I only charge patients for the procedure. Okay, I'm not charging them for as if they had scaling and root planing. They're only getting the same as if they had osteosurgery. It's also based upon the difficulty. If I'm seeing someone that has 9s all the way around, that's a different fee for someone that has no furcations. You know, there's all kinds of factors. I happen to feel that degree of difficulty is very important, so that not everyone is the same situation. But most of the time, I'm happy to say that in my office, it's cheaper than if someone came over for 4 quadrants of scaling and root planing and 4 quadrants of osteosurgery. I think that's a deal.
Well, I've been told in the past, Lil, I know if you were going to do like a full mouth, that there was always a basic starting fee of $4,300, $4,600.
Look, you want you know what? You know what? I can tell you, it could be anywhere from $3,500 to $5,000.
Okay.
But I think the better point is that you're eliminating a step.
Absolutely.
You know, so and also you're eliminating visits. I mean, you want to drive to me 12 times or 2 times?
And I mean that brings up a point when you say you're eliminating the steps, as us hygienists who have gone in and you know we are doing the scaling and root planing, and some of us that have been in the perio office and it's been flapped and we've been in there and we do the scaling and root planing. Where in the realm of laser will a hygienist be able to do some of this? You know, I mean, I know it's not now, but
well, are you asking me when will you be able to use a laser?
Yeah.
I have no idea.
Well, but it's like I understand that, but it's like I almost feel like you're taking some of our fun away from our.
Well, you know what though? I understand what you're saying, but I would like to think of it that I'm doing more to help the patient than, you know, but I hear what you're saying, and you're right, but it's more important.
I mean, that's a challenge for us.
It is a challenge, but if you think about the patient, then that challenge goes away a little bit. Yes. It's okay.
Let me preface this by saying I am very on board with lasers. I think it's the way of the future. I think it's great. We've had the same law now for a year and a half now, and you know we're very excited. But just in the last like 3 weeks, and we were able to probe. It's been a year and a half.
Yeah.
The tissues look great.
Yep.
The probing depths haven't changed, and so I'm a little disappointed. And I don't know if it's. Do you think it could be operator error? I mean, not to throw my boss under the bus, but scaling calculus isn't his forte, and so I don't know if maybe that has something to do. You know, I'm just.
Well, you know, look, the only way I can possibly answer it is.
I mean, if there's residual calculus left, is that going to affect?
Well, theoretically, maybe not, because the laser does something to calculus. It denatures some of the protein. It gets rid of the bacteria in there. And there's actually some thoughts about calculus anyway that, you know, you don't have to get rid of all the well, but that's a whole different thing. That's the biofilm lecture. We're not doing biofilm. I don't know, except to say that it's like saying, you know, when you have osteosurgery, did you get rid of all 164 pockets? Okay? You tried. You got to follow the protocol, and some of the starting points might have been extremely deep, and as long as I think progress was made, then I think it's okay.
And tissues look great.
The tissues look great, yeah. I mean, in a smoke, you know, the patient's smoke. I mean, there's a lot of factors, you know, home care, a lot of factors. I don't really know. I think occlusion is real important. It's real important with this technique. And if the occlusion isn't taken into account big time, not just night guards, because during the day they're not wearing night guards. the occlusion's a big deal with this technique. And mobility's a big deal with this technique. You can't have any. You just can't. So those are some, that's what I'd throw out to you. I'm not really sure. Yeah.
When you do one-off at your office, do you do the laser and then do hand instruments also? Like, are you doing kind of like scaling and replaning along with a laser?
I use a piezo machine.
Yes.
You don't use any scale.
I will if I get into a situation where I can sort of feel around and come up with something. Oh, let me, ladies, if you give me a form, an evaluation form, I will give you 2 hours for nothing. Whether you liked it or not, but it's out on the table, so you can have your form. If you have to leave, it's fine. I have no problem with that. I'm sorry, where were we? Oh, about the hand instruments. I use the piezo primarily,
Yes.
absolutely, and I use hand instruments only occasionally.
Why do they think the Piezo is better than Cavatron?
Well, I'll tell you, I will tell you personally, a piezo is like using dynamite underneath a flap or underneath tissue. I can't give you the scientific reason. I don't know. I love it. I wish I had gotten one sooner. Now, the machine that we have is a really fancy machine. You may have the same one. It costs a fortune. I love it. So the tips are really, really fine, and you can get in there, and they come in a few different shapes. And when I do it, I change the tips so that I'm using different tips in the procedure. I absolutely love it. It's not like a Cavatron at all. Yes?
What's the name of your Piezo?
I don't know.
Good name.
I don't know. It's on the. It's you know what? It's the piezo machine is part of the package of what we
EMS
is it EMS? It's on the box.
I'm using the symmetry, and I love it much better than the dentist by Cavatron. I especially love the
Yeah.
the light that's on.
If you call my office, I'll get the model number for you if you want. I don't know. It's in a box. It's on the box. It's on the machine, but I don't really pay attention to that. Yeah.
I have a question.
Just a second.
Have you seen the patients with a chronic gingivitis around the anterior crowns, usually in
Uh-huh.
the 8, 7, 8 area?
Uh-huh.
Will this technique help with that?
How can I answer this diplomatically? It will if the crowns fit. I mean, it probably wouldn't be the first thing I would do. I would be real careful to say that this would be a situation to use that. That could be just iatrogenic dentistry. And I would say that this would not be for that. But, you know, every case you judge on its own merits. But you asked me, so that would be my answer. Yes? Yeah, let me clarify that. It doesn't matter what technique you use to get your result. Insurance is not an issue. In other words, it's coded as osseous surgery. So there's no laser code, it's nothing special, there's nothing about it that a patient would have to worry about. We file this absolutely the same way. It is zero problem, without question. Okay.
Smoking, a smoker.
That's
Okay.
what I was going to ask. Do
Go
you
ahead.
have any reservation about doing this procedure on a smoker?
No, I think it's fabulous for a smoker, because if I do flap surgery on a smoker, oh my God. I mean, they can have, you know, listen, if you limit your practice to non-smokers in Jacksonville, you're not going to be here very long. But if you do periosurgery on a smoker, which I do, it's not pleasant. Yeah, the healing is slow. The oral hygiene is impossible. The roots are yellow. It's a difficult thing. If any type of patient would benefit from this, it's a smoker. Now, I can't tell you that we're going to grow bone all the way up, but you know what? This is exactly what you want to do for a smoker, because flap surgery is really tough.
Because in the past, it was just like, you could tell them, well, it's just a death sentence. You know, it's like, you're smoking, yeah,
Well, it's just tougher.
yeah.
Yes?
Most people have inflammation in the area, but then you have the patients that have the pocketing and they're really not puffy bleeding. Would you still use a laser on those patients?
Non-bleeding.
The one, they don't have bleeding, they're not smokers.
But they have pockets?
They have pockets.
They have bone loss?
They have bone loss.
Absolutely, without question. And I think that the occlusion needs to be looked at too. Well, in fact, I would tell you that that's the kind of patient I would treat. That's the kind of patient I'd want to treat. They'll probably heal well.
And you do localized. You don't, with this lineup, you do localized. You don't do the whole.
Well, you mean, are you, okay.
Because there have been times when.
Look, I know what okay, what you're saying is, let's say I'm doing 2 through 6, and 7 and 8 have 2 and 3 millimeter pockets. Are you saying, you're asking if I'm doing 7 and 8?
Right. There are like maybe 2 teeth that are compromised, that have pockets, and he'll do the whole, because this is kind of their protocol, because
it is the protocol. But it is the protocol, but you know what? The answer to your question is, it depends. I think I know what you're asking me. The answer is, if the patient has 2 and 3 millimeter pockets, and I've ascertained that at a diagnosis appointment, and there's pretty much health as I can, the answer is no, I would not do that. Because, again, going back to insurance, there's a code 1 to 3 teeth. And then there's a full quadrant code. I mean, I'm all for doing 1 to 3 teeth if they only need 1 to 3 teeth. It's true, the protocol is to, but it's a judgment call. I'm not looking to treat health. So does that help?
Yes, a lot. Thank you.
I'm not looking to treat health. I'm looking to treat what needs to be treated. All right, who's left? What I do to make this side of the room mad? Everyone on this side had wine. You guys just had water. Oh, you okay? You hang around. Okay. Yes.